Good morning, everyone. Since I have only 10 minutes, I'll be focusing on unresectable lung cancers. I'll not be dwelling into the post-operative management of lung cancer. And obviously, because we're talking about radiation therapy to a mixed audience, I would be talking briefly about the standard of care, the current standard of care, what are the challenges with the current standard of care, and what are the advances and how the future standard is going to look like. RTOG 0617 trial is probably the most seminal trial in this setting, and a lot of our care currently is guided by this clinical trial, which is essentially a randomized trial of concurrent chemoradiation of using two different dosage. One is 60 gray, which is standard, and other is 74 gray, which is dose escalated radiation therapy. And apart from that, there was a small randomization of cetuximab, but that was not very relevant to what I'm talking about today. But what it essentially showed is that normally we see in escalated intensified arm should look up, the graph should look up, and in fact they were actually inferior to the 60 gray arm, and therefore the cancer related deaths, but if you see the cancer related deaths were very similar between the two arms, but more treatment related deaths in 74 gray. That means toxicity was contributing to deaths. The higher heart V5, which is volume of heart receiving 5 gray, was much higher in patients who received higher doses, higher non-compliance to chemotherapy, and prolonged overall treatment time. As you know, in radiation oncology, as the overall treatment time is prolonged, the outcomes are inferior. So this was essentially, of course, there are about at least 30 publications on RTOG 0617 on various aspects, but this is the essence of that clinical trial. And based on that, we follow our current gold standard or standard of care approach for unresectable non-small cell lung cancer. Concurrent chemoradiation is a standard of care, of course, in a suitable patient. 60 to 66 gray is considered the standard. IMRT is preferable. I would not say it yet as standard of care, but it is almost a standard of care. That's why I put it in orange, but it should essentially, whatever technique we use, it should satisfy the dose volume constraints for lung, heart, and esophagus. The mediastinal staging is essential for a radiation oncologist. So if I don't have a PET, I really cannot give effective treatment. I'm not saying PET is a good enough mediastinal staging, but at least a PET scan must be present, because if you treat elective nodes, if you treat all the nodal stations, it is of very little benefit compared to you treating only those nodes which are involved. So involved node radiation therapy is the standard of care instead of elective nodal radiation. When we deliver radiation in thoracic cavity, where tumors are moving, motion management strategy is essential to deliver an effective treatment, and at least a type 2 algorithm, which essentially takes into account tissue heterogeneities. When we talk about tumor, bone, and air interface, when it comes, the dose calculation may not be very accurate, and therefore the modern systems, all we have is have at least type 2 algorithms, which essentially ensures that the dose calculation is accurate. And of course, as I mentioned, complete treatment without any major interruptions, because it is a toxic regimen, concurrent chemoradiation in certain patients, especially in poorly selected patients, and therefore the overall treatment time should be below 7 weeks. So this is the gist of the current standard of care we have for radiation oncology. But of course, there are some patients who are not suitable for concurrent chemoradiation. So what happens to those patients? For those patients, sequential chemoradiation is quite an acceptable treatment compared to, say, giving only chemotherapy or only radiation. Sequential chemoradiation is definitely an option in those patients who are not suitable for concurrent CTRT. And of course, when I mentioned 60 grain, 30 fractions over 6 weeks is a standard, and hypofractionation schedules have also been used. Multiple prospective as well as large retrospective studies have shown that moderately hypofractionated regimens seem acceptable, very little difference in the outcomes. So if you use a fractionation scheme of, say, 55 grain, 20 fractions, so that you complete the treatment quickly and send the patient to systemic therapy, they are quite acceptable, and they are quite extensively used in United Kingdom, and therefore we are using it as well in certain patients. So coming to, this is the standard of care, but what are the key challenges for thoracic radiation oncologists is that if you see, as you go by the randomized control trials, These are the criteria, strict criteria for recommending chemoradiation, and these patients only were accrued into clinical trials. Younger patient, fitter patients, patients who have good pulmonary reserve. But if you use these criteria, up to 1/3 of patients below 60 years and up to 50% of patients above 60 years are actually not suitable for concurrent chemoradiation. So this is an important issue with patient selection for us. And among the few sites where acute toxicities, normally acute toxicities should determine quality of life. Acute toxicity should determine overall treatment time. But acute toxicities determine overall survival in lung cancers. Very few areas in the body where acute toxicities determine overall survival. And even DVH parameters, which is like lung or heart V5, not just determines toxicity, but also determines overall survival. So this is an important challenge for us. There is, of course, the issue of subacute grade 3 pneumonitis, which is seen in about 5 to 10% of patients, fortunately getting lesser and lesser common because patients are getting more conformal treatments, but there are 2% patients also have fatal pneumonitis. The cardiac toxicities are real. There is a lot of understanding, and there is a myth among all the even oncologists that cardiac toxicity is a late toxicity, happens after 4 or 5 years. Lung cancer is probably not relevant. Not really. The toxicities can happen irrespective of previous cardiac risk. It can happen within 2 years, as early as 2 years, and therefore it is important to understand cardiac sparing is essential for thoracic radiation therapy. And who are more vulnerable? Patients who have subcoronal nodes, patients who have multiple nodal stations involved, where the chances of cardiac irradiation is higher, or patients who have N3 nodes, especially the contralateral hilar nodes. They seem to have a high propensity to have more cardiac irradiation. So despite giving about 70-80% grade 3 hematological toxicities, about 20-25% grade 3 esophagitis, we have underwhelming clinical outcomes with chemoradiation. The local failure is about 40%, regional failure is about 35%, distant failure close to 60%, and only 30% of patients remain progression free at 2 years. Only 30%, which fortunately was improved due to addition of consolidation immunotherapy with survival changing from mid-30s, 5-year survival changing from mid-30s to mid-40s. So you can see that it is underwhelming clinical outcomes despite a lot which is being done. There is also, because now that immunotherapy is in the picture, when we use a technique such as VMAT or IMRT, we give low dose radiation to almost entire thoracic cavity and therefore circulating lymphocytes as well. And it is well known that radiation does cause lymphopenia or leukopenia, and this seems to be correlating with overall survival in these patients. So this is an issue as well which we need to address, especially when we are combining immunotherapy regimens along with radiation therapy. So essentially we have done many tweaks around the treatments, around the chemoradiation backbone. Use consolidation chemotherapy after chemoradiation, use induction chemotherapy before chemoradiation, added surgery to chemoradiation. Nothing worked, unfortunately. Multiple trials have shown that nothing else worked except when we use, as of now, consolidation immunotherapy as shown in Pacific trial, or the recent LAURA trial which showed consolidation osimertinib, which seemed to be working. We are yet to see for other targetable mutation, but this is the only approach which currently seems to be working. But in stage 1 lung cancers, we know that higher the dose, the better is the local control. Can we extrapolate this from stage 1 to stage 3? And does higher doses lead to higher local control in stage 3 as well? And the second question, does higher local control lead to higher overall survival? There seems to be some evidence based on the clinical trials we have that higher the local control, there seems to be some slope. The y is equal to, when we say mx plus c, m and c have finite positive integers. That means there is a slope of that curve. It's not a flat curve. So local control does contribute to overall survival. So way to optimize is to use hypofractionated regimens, give shorter treatment time so that you effectively increase the doses, or do selective tumor dose escalation, whether use a PET or use another imaging modality to increase the dose, or use molecular information to increase the dose to a certain areas, or use particle therapy, which is essentially giving higher biological doses. So essentially one of these have to be used to ensure that we optimize the radiation. IMRT, of course, known to reduce the toxicity grade 3 pneumonitis by more than 2x. So IMRT should be considered standard of care. It also reduces the V40 of heart, which is volume receiving 40 gray of heart. Essentially, recently we found out that V40 should be less than 20% at least, based on RTOG 0617. So there is also RTOG 0116, which essentially evaluated dose escalation to PET avid areas only to 80 gray, and even that you can see that the 2-year in-field primary tumor control was actually better. Loco-regional control was better, but overall survival absolutely no difference, which was the primary endpoint, and it led to higher toxicity. So we need to escalate the doses not in the conventional way, but in a smarter way. One option is use of particle therapy, wherein you can considerably reduce the dose to the heart and lungs, and therefore you are not contributing to the toxicities. There are 2 open randomized trials. Both are phase 3 randomized trials, which are evaluating protons in this setting. So SBRT, can we use SBRT for, we are using SBRT for stage 1, can we use for stage 3 lung cancers as well? There are multiple settings, both definitive SBRT as well as SBRT used before or after standard fractionation use of SBRT boost. In fact, some investigators are proposing incorporating SBRT into the framework based on the response and based on the initial tumor volume, whether the tumor is less than 7 centimeters or if there are only single nodes less than 3 centimeters in the mediastinum. So to conclude and summarize, performance status, age, lung function, tumor volume, location, they all remain key for patient selection for chemoradiation. Mediastinal staging is essential for effective targeting with radiation. There's no role for elective nodal irradiation. At least 60 gray EQD2 over 4 to 6 weeks. IMRT reduces grade 3 radiation pneumonitis by more than 2 times. We need smarter dose escalation. If we just escalate doses by increasing the duration of treatment, it doesn't seem to be helping, and therefore hypofractionated regimens while sparing heart and lungs should be the key. And it is undergoing further evaluation, and consolidation therapies are evolving. Thank you very much.
So thank you so much. Now I have a couple of questions. So you said in one of your slides, you said that patients, 50% of the patient more than 60 years of age is perhaps a bad candidate for CTRT. So can there be an option of NACT or neoadjuvant immunotherapy in such cases to downstage the tumor and then to go for the full dose of CTRT? My first question. Anyway, we'll go one by one.
Yeah. So that study was a Swiss study, which actually evaluated based on the criteria used for accruing into clinical trials. If you use the same for in a real world scenario, that is the scenario. Many borderline in our clinic, we do treat patients above 60 years, and majority of them we would go concurrent chemoradiation.
Also, if the patient is not a fit candidate, that the patient will tolerate the
so sequential chemoradiation is an option. I understand what you're asking is, can we introduce immunotherapy in that? There is very limited data for neoadjuvant immunotherapy in the setting of chemoradiation. At least not phase 3 randomized trials are not yet there. But there are multiple studies which are evaluating it currently, that addition of immunotherapy before part of induction chemoimmunotherapy before chemoradiation. Multiple studies are evaluating that.
But still we have not come to
not
a
yet,
conclusion.
yes.
CTRT plus immunotherapy versus CTRT. What's your take?
There is a randomized trial, so there is nothing to say.
There is something like effect
both,
of immunotherapy and radiation. How do you rate that?
So there is a synergism between radiation and immunotherapy. That is very well established fact. And in fact, that the Pacific trial also showed that early initiation of immunotherapy after chemoradiation seems to be working better than delayed initiation of immunotherapy. within 4 weeks is what is now recommended. So there seems to be some synergism, and therefore it is radioimmunotherapy, chemo immunotherapy is here to stay in unresectable lung cancers.
So for invariably in all squamous cell cancer, we after post CTRT we give durvalumab. That is the standard of care. So how long do you want your patient to wait before we start with our
4 weeks.
immunotherapy?
4 weeks.
4 weeks. And suppose the response is not very adequate. We have still a partial response. So what's your take on that?
4 weeks is very early to assess response, I believe, and ideally we should do a PET, and PET for 4 weeks. PET is very. I will not believe that PET completely. Therefore, we start immunotherapy irrespective of the radiation response.
Being given by CTRT.
Yes, but there should not be any progression. If there is any progression, then obviously then we are giving immunotherapy for a different reason.
Okay.
Just 2 points. I think, are you telling that why we do a PET scan rather than a CT scan after CT?
No. Not at 4 weeks.
So my with the same thing, that one came out, I thought we should go out that CT scan is what a modality will does.
Yes.
It will give us a lot of
Wrong information, and in fact will probably misguide us.
yes, we'll have lot
Absolutely.
of pseudo-progression.
Absolutely. So that's why immunotherapy should be given. If there is a plan for immunotherapy, it should be given irrespective.
No, though we do a CT scan, if there's no PD.
Progression, yes.
Number 2 point is the concurrent which you spoke. Pacific 2 has addressed that. It's a negative trial. So concurrent durva with CTRT is negative.
No, she didn't ask that. She asked for induction chemoimmunotherapy.
Yeah, it's the second question was also.
Okay.
Triple
Yeah,
combination.
Pacific 2. Yes.
I think the message should not go.
Oh, yes, of
So
course.
concurrent is out. We know that there's a maintenance consolidation, whatever you tell, of durva 1 year in the right patient. I think that's what it is today. And
So for durva, you have to have a complete response before you start?
No.
Non-progressors only are excluded, and patients who have had anything worst response as a stable disease also are eligible for the maintenance 1 year of consolidation durvalumab. Some patients do not benefit, that we will discuss. The EGFR group and others.
Patients who have targetable mutations doesn't seem to be helped.
That's my talk. So
One of my patient, Dr. Sahu. So, Dr. Sahu, I have one of my
So
patient.
you have finished the talk then.
So I have one of my patient post CTRT. It's almost 6 weeks post the patient has undergone a PET scan. The PET scan is not giving me a very clear picture whether the patient has a complete response because the SUV uptake is a borderline. It's resolving. They have mentioned it's a resolving phase of a lung cancer. So I was just confused whether we should take it as a response. I have to wait another couple of weeks to have a response to start durva.
is eligible for durva and can afford it and the right patient, I'll give it.
In fact, if you are waited up to 6 to 8 weeks to do a PET and found a residual node, I would in fact ask my surgeon to look at it and then see whether any salvage surgery can be done.
So thank you so much. The organizer asking me to close the session. We are running short of. So let me